cytokines to accelerate orthodontic tooth movement. We can use mechanical forces, and we can also use scaffolds. So we have used all these, and I want to show you some of these examples of these cases for us. So tissue engineering in medicine is a big subject, and a lot of people are doing it. But in orthodontics, over the years, we are going backwards instead of going forward because we are all into aligners, and I want you to think above and beyond aligners also. So I'm going to show you. I have cleaned it. And in each example, we have maybe 15, 16 patients over the years. This is a patient was brought to us by Protestant missionaries. Apparently, she was from North Vietnam, and I don't know how she managed. They brought her into U.S. and they brought her to our clinic, and they said, "Can you please take a look at her dentition?" And we looked at her, and you can see there is a complete deep bite in this patient. Upper incisors are completely covering the lowers. The occlusion is asymmetric between the left and right sides. But the biggest problem I want to show you is if you look at her left upper incisor, and you are going to see that there is bone loss in this incisor. And I want to show you, because you know how I would be treating the lower arch, because in the lower arch, we are going to be intruding the lower teeth, lower incisors. Upper, we don't want to intrude. But what I would like to show you is how are we going to manage this thing, this bone loss. Okay, so let's take a look at it in this patient. So, if you look at, we don't want to go into periapicals, but there is a lot of bone loss in this patient. So, the problem is the incisor. There's a complete loss, gingival margins are way off. One bone is here, one bone is all the way off. So we look at three different possibilities of treatment in this patient. So you can see one would be that we can do debridement with GTR, gingival tissue regeneration. And we can probably get bone deposition, attachment, limited regeneration, likely result in gingival tissue. So when we look at it, we look at the literature. What does the literature say? Okay. And then we can do orthodontic eruption of upper incisor. If I do upper incisor eruption, the bone is going to come along with the
nó sẽ mọc theo. Đó là cái cách ở giữa đó.
The last one is
và cái cuối cùng á, đó là cột
that forced eruption, but there are a lot of issues and problems, but this is what we decided we would like to do. Orthodontic eruption, because we want to obtain the bone height, and then we can move the teeth left and right, back and forth, so that we can grow the bone. So we are not interested in saving the tooth.
Chúng ta không phải giữ cứu lại
We are interested in
chúng ta quan tâm đến việc là mang xương xuống, mọc xương xuống, và chúng ta đang làm cái đó gọi là tissue engineering, công nghệ chúng ta nghĩ các bạn là ngoài cái aligner chỉ là di chuyển răng thôi, chúng ta có thể tạo lại xương theo cái ý của mình bằng thông qua cái việc.
So there's our patient.
Thì đây là bệnh nhân của chúng tôi.
So take a look at it. Gingival
Hãy
margin is
vào cái
here.
điểm yếu
This
của
one
các
is
răng này.
way up. A
Thì
lot
cái
of
này chúng ta thấy
variation.
2-1 nó lên trên và
So we are
có
going
vấn
to
đề về
send
nha
this
chuông.
patient to a
Và chúng ta gửi
periodontist
cho
so
bác sĩ
that.
nha chuông.
So we are going to provide free
Và chúng
treatment
ta sẽ
because
điều
she's
trị
coming.
bởi
She's
vì
basically a refugee.
và bên đây là người tị nạn và được mang đến bởi một người truyền giáo, tức là
mission is they want to take care
và
of.
cái nhóm mà truyền đạo đó tức là nhờ.
So if you look in here,
Và đây
what we are
thì
doing
chúng ta thấy
in there.
ở đây
We use intrusion
chúng ta sẽ
arch
dùng cái cung
upside down
và
as
đầu ngược nó
extrusion
lại để
arch.
chúng ta thành cái cung trồi.
We are going to apply
Và
a
chúng ta
force
sẽ đặt
of
cái lực
10
áp 10
grams
gram
on that
và
incisor.
ở trên răng cửa có 10 gram
And
thôi.
only
Và
the
chỉ
wire is going to be attached
như vậy
with
thì
that incisor
với
up
cái
there.
răng một cái mắc cài
And
ở
we are
trên
going
răng
to
cửa
do
thôi.
endodontic
Và sau
treatment
đó
in
chúng ta
that
sẽ dùng
incisor.
cái làm nội nha cái răng đó.
Every time patient comes
Của
in,
răng ngoài
we
chân
are going
đến
to
á,
measure
và
the
chúng ta
force.
sẽ
We
đo
are
cái
going
lực
to keep
và
the
chúng ta
force
sẽ giữ cái lực
anywhere between 5
và
and 10
khoảng là
grams.
từ 5 đến 10 gram thôi.
So, what we are going to do is, when that incisor is coming down, I don't want the incisor ledge to extrude down, so I am grinding the incisor ledge.
Cứ trầu bao nhiêu á là tôi mài răng cửa
Okay.
đây.
And then what you will see
Và các bạn sẽ
is
thấy
we are making the tooth
và chúng ta sẽ
smaller,
làm cái răng
and I'm looking at
nhỏ
the
hơn,
gingival
nhưng mà càng hơn,
margins
nhưng mà
are
cái yếu
becoming
á, thì
equal.
nó sẽ trở nên
But in
bằng
the
phẳng.
meantime,
Và
patient
đồng thời á,
doesn't like
và bệnh
the
nhân
teeth, so I kind of build up the
và
tooth
chúng
a
tôi
little
sẽ
bit
đắp cái răng chút
with bonding
với
agent.
cái
Further material.
vật liệu dán đó, tức là đắp thêm composite để
I extract 2 teeth in the one premolar in the upper,
và gàn nhổ hai
and
cái
I'm
răng
going
cái là
to
răng cổ
use,
nhỏ
now
hai
you
bên.
can see force
Và
system,
chúng ta thấy hệ thống lực
but I bypass this
và
tooth,
chúng
I
tôi bỏ
don't
qua cái răng
engage
này,
in the
chúng tôi
wire
không có
at
đưa nó
all.
vào trong cái dây cung và bỏ qua cái răng này.
So, what we are basically doing is these X-ray you don't see very clearly is that we are extruding, and the bone level, which is way different,
và nó rất khác
the
nhau.
bone level is going to
Xương nó
come
bắt đầu
down.
nó đi xuống nó khác lúc ban đầu rất là nhiều.
Okay.
Cái đó gọi là tissue adhesion.
So now, what you will see here is we are using straight wire mechanics
chúng ta dùng cơ học là dây thẳng
to align the
để
upper
làm thẳng
teeth.
hai các cái răng.
And you can see
Và các bạn
here,
sẽ thấy ở đây,
at this stage,
ở trong
we
cái đoạn
are
này,
sort of looking at
và
this
chúng ta sẽ
gingival
nhìn vào
margins.
cái
We take the X-ray in the patient, and we look at the bone levels
chúng ta nhìn cái
if
mức độ
they
sống
are at the same
và
place.
coi thử nó có cục ngang của cây không.
We also
Và chúng ta
move the
cũng di
teeth,
chuyển các cái răng
I mean that incisor
và
slightly
cái răng cửa
buccal
nó
and
ra phía
lingual
ngoài
because we
trong
would like to build
và
up
bởi
the
vì
bone
chúng ta
there
đắp
also
xương
in
theo
this
cái chiều
patient.
đó, theo cái hướng đó.
What we are going to do in this patient is we are going to basically pull that little tooth down.
Kéo cái răng đó xuống.
And then what we are going to do is we are going to place an implant. And I'll show you, we don't like to put implants in the aesthetic zone. But in this patient,
Nhưng ở bệnh nhân này
there are very few other
và
possibilities.
có ít khả năng để đến cái vùng đó quá.
So now what you will see
Và
here
các bạn
is
sẽ thấy ở đây.
we bring it down, we put it here, and we tell the patient to smile as wide as she
Cười
can.
to nhất,
And you don't
cười
see
hết cỡ.
the gingival
Chúng
tissue.
ta không thấy có lộ nước.
I have about
Và
150
chúng ta thấy
slides
và
in this
có
patient.
200 về
Taking the appliance out, taking
chúng
the
ta thấy slide
X-ray.
là chúng tôi
We
có rất nhiều
developed
slide.
so much bone
Và
that
chúng
we
ta
had to
phải
grind
rất là
some
nhiều và chúng
bone
ta cũng phải
off
bài
when
xương
we
và xương
placed
nó
the
nhiều quá đến
implant
nỗi
so
chúng
that
ta phải
gingival
bài một xương
margins
chúng ta
will
cắm
be at the
implant
same
ra
level.
để cho nó có cái
Okay.
giao trai cần thiết.
So buccal occlusion looks very good. Plaster on this side, midlines are on.
Dạ.
Patient in 2 years is completely Americanized.
Và trong 2 năm là
Completely.
Mỹ hóa, tức là từ một người tị nạn trở thành
It
người
just
Mỹ hoàn
changes
toàn,
completely because
thay
she
đổi
has
hoàn toàn. Bởi
self-esteem,
vì
she
có
feels
một cái
much
sự
better
tự
about
tin và
herself,
của
totally
và
different.
của
Married
tự tin về
in
đó.
2 years during the treatment.
Và như vậy là lấy chồng trong 2 năm đó.
So you can see
Và các bạn có thể
when
thấy
she came to us
và khi cô đến với
and
tôi
during the retention
và
phase.
sau cái giai đoạn gì
So I like to always show this
và
because
cho các bạn thấy rằng
there are very few choices
và
you
có
will
rất nhiều
see.
sự lựa chọn.
when you are placing implants in a patient like this. I hope I have pictures.
Và tôi hy vọng là
So now you will, I think this is, I think after 10 years.
và đây là 10 năm đó. Đây là cái
Because we have pictures 10 years later, what went on with this patient. I have pictures of her. We have followed her up to 15 years,
Vậy thì có 15 năm,
13 years.
15 năm,
No change,
3 năm
beautiful
không có
result
thấy
in
kết
this
quả rất
patient.
là tốt.
So this is the simplest
Đây là một cái
example
ví dụ
of
rất
tissue
giản của
engineering.
cái tissue engineering.
We're going to go more complicated as we go along.
Chúng ta sẽ đi sâu hơn nữa để cho hiểu về
So, tissue levels are different,
và
bone levels are different. You
mức
can
độ khác nhau,
exclude
mức
the
độ
deep
xương khác nhau,
bones
chúng
where
ta
you
có
come
thể
with it.
chuyển răng để cho nó điều khiển nó
Ridge augmentation.
và chúng ta thấy là cái
This is another patient.
đây là một
She came to us near our school.
và cổ tới với chúng tôi.
There's a small town, New
Có một
Britain.
thành phố là New Britain
60,000 people. I think about 35,000 are from Poland.
và trong đó có 30%.
And they basically work in the university. They're, just managing, the lawns and the offices and everything. And every year they bring cousin, uncle, everybody's coming in from there.
bà con rồi tới cái trường đại học.
So this person took care of our offices in orthodontics, and he says, my cousin is coming. I want to bring her.
Như vậy có một ông bệnh nhân đó thì có một cái cousin đó, một người.
He brings her, and we look at her, and we say, oh my God, what kind of dentistry she had. She was from a small village, Polish, Ukrainian border. Every time she went to see the dentist, pull the teeth. Anytime she had a problem, there was no restoration. And this is how she was. She's about 21 years old when she came to us. So, this tooth, take a look at it. Here you will see no teeth. Extraction. But what we are going to talk about here is, take a look at this. You can take your little index finger and you can put it all the way in because there is so much depression where the lateral incisor was pulled a long time ago. The bone is gone and the depression on both sides. Completely. No bone there at all. Here also you will see that bone is almost like knife edge. Okay, so now, so we look at this patient's history, look at restorative dentistry. She needed so much work. I don't know what's going on there. Just to show you a few of these pictures. Now you can see what kind of endo went on there, extraction of the teeth. You can see what's going on here.
Các bạn thấy những gì đang diễn ra ở đây đây.
This thing is very slow. I have to go there.
Cái này nó chuyển chậm
Thing
quá.
doesn't work. Okay, I'll stay here
Dạ, tôi ngồi đây
so we
để
can move faster.
chúng ta di chuyển các slide nó nhanh hơn.
So now you will see the summary problem. There's no problem with alignment, no problem with transfers, no problem with AP. Little bit, So skeletally there are almost no issues in this patient. So treatment objectives, you want to maintain everything, but you can see the overall, she needs a lot of problems. So one of the things we did in this patient is that we said, let's take a look at the models, what else can be done in this. And this is done primarily by the prosthetic department. because we sent her to the prosthetic department, and they like to do something like this, and they came back, they said, well, you know, she's going to need 2 implants in the lower, she's going to need implant in the upper, what can you do with that space, with the lateral incisor? Okay? So now you are going to see that what we are going to be doing in this patient. So we are going to show here how we are going to manage that depression in the lateral incisor area. Okay? Tissue engineering. We are talking about. So first thing what we did is we put a little flipper. And she was so happy. She couldn't even believe that she could smile with all the teeth in the front. You know, we just took an artificial tooth, put a bracket on it, and we just put it on the outside. And bonded it so that it doesn't move too much. This is the area I'm going to concentrate. So what are we going to do with this? You know, we are doing rotation of the teeth, alignment. I want to finish as much as possible the arch wires in this orthodontic treatment before we start doing our tissue engineering. So take a look at the occlusion is looking pretty good, and we are almost at 1 year mark at this time. So treatment is progressing very nicely. Incidentally, she just came to visit US and she never went back. It's like applied to get a visa and everything. She got it. In those days it was easy to get it. Okay. So now we go back to our this. So now we talk with our oral surgeon. We have already discussed the treatment plan with him that this patient is ready for our treatment. So what do? We go to the anterior border of the ramus and we take a piece of bone. And we are going to cut this piece of bone in 2 parts. Okay? So we just go on one side, we cut the bone in 2 parts, and we are going to take that bone, open up that space, take that bone and stick it there in 2 titanium screws on each side, and put the flap back on, and start orthodontic treatment all over again, you know, whatever is going on. So what we are doing is using this autologous bone, putting it in the patient, in the missing lateral area. I can do this in premolar area, anywhere. But this is what we are doing. Suture it back, and basically start treating the patient, what you are doing. And we take X-ray and we follow what is going on in this. So we are basically going to do is gradually anterior. Now we are putting heavy wires, aligning all the teeth. Flipper is there, bonded there in that space. And at the same time, you can see a little bit darkness where you have your screws there. Day 29, we go in, and I would say it takes about 3 months, 2.5 to 3 months. And what we are going to do is, we are going to go and prepare that side. So what we are going to do is make a flap, check how the bone looks like. There should be a total integration of the autologous, what you have put in, and the existing bone. Completely. We take the screws out. We also prepare the same visit, an immediate implant in the lower also. So we go in, place an implant, place bone around it, close it up in the patient, completely.
hoàn thành hoàn tất cái cao.
These are our implants in the lower.
Và có cái phần
Now we go in the upper.
và bây giờ chúng ta
We are ready.
chúng ta đã sẵn sàng
We open it up.
mở ra.
Take a look at the bone. It has become part of the, and the bone has, there's a lot more bone than we really need. We have to take it out.
Và chúng ta phải mài bớt xương đi.
We are going to go back in
Và chúng ta quay trở lại
and place 2 implants.
đặt 2 implant.
Again, these are the cases where you are not worried about, oh, whether the patient is going to show implant or not. We are trying to do total reconstruction in these patients. Suture it up,
Phải tạo lại toàn bộ cái
basically try to finish the patient.
bệnh nhân sẽ được cái hoàn tất cái lần tức là tàu.
These days, implants are much smaller.
Và bây giờ ngày nay
And now we basically have a little flipper going on there again. And now, take a look at this bone. That complete depression is gone. We made bone enough for an implant. And now we have this patient. So there she is. Totally different. Americanized. And now she comes to us and she says, I'm going to Poland. So why are you going to Poland? I have my visa and I'm going to get married. I have a boyfriend. I said, you have a boyfriend? You never told us you had a boyfriend. She said, yes, now I'm going to get married. So can you take everything out? Oh, wait a minute. So we are going to take everything out. But, you know, we haven't put in a molar there and we haven't put in prosthesis. So, well, you know, we do something temporary there. So in the posterior, we just put a wire in there to hold the space. And here we said, okay, you know, let's give her some kind of a... Okay, so there she is. She goes for her wedding. There we are. No change because there was no problem. And now you can see she has everything in the mouth. Before and after, complete change. This is how she was. This is how she is when she gets everything done. She sends a picture. She got really married. You are not sure. And she works at the dental school. She's a dental assistant. But she didn't want to work in orthodontics because she says everybody wants to see what's in our teeth, you know. So she works in the oral surgery department at this time. So I just want to show you guys that you can do amazing things with some of these patients. You know, don't give up on these patients. You just gotta think. Work with your oral surgeon, work with the endodontist. The only thing is, if this patient was paying for everything, it was almost like a small Mercedes car she would have paid, but she got all the treatment free. She got more endodontics than you can think of. Orthodontics, oral surgery, the implants, taking it out, putting it in, all those things. Take a look at another patient. She's an all-American woman, right? She comes to us. So what's going on in your mouth? Well, this is the way the things are. You can see. Look at the amount of bone loss which has taken place on that side. She also had a dentist. Every time she had a problem, he pulled the teeth out. Okay? We asked her, where did you live? She was living in a commune
Và ở
You,
trong
you all know what communes
các
are?
bạn là trong công
Some
viên
young people check out.
như vậy
They
bệnh
go,
nhân
they live in a little town, remote. There's one guru, everybody lives there,
và có
and
một
she
cái
was,
khu tập
she
trung
was
ở
living
đó
there
và ở trong công
for
viên
several
xã.
years. And somebody was pulling all her teeth out
Như
at the
vậy
mouth.
thì là trong cái gọi
Her family brings her to us and say, we would like some orthodontic treatment done in this patient. And now what you will see in a patient like this is that one of the things we started doing, because her bone loss was so much, that we started putting some pads in the edentulous side and using exclusive forces on these pads. So we can put 2 or 3 pads in the edentulous side and see if we can grow the alveolar bone a little bit. Not much, but you can do some very exciting things. So we are in big favor of using tads, small tads, 5-6 millimeter in the edentulous side if you want to move the teeth, because we can put artificial teeth on top of it. So you will see in a patient like this, we are moving teeth in that side, both in the upper as well as the lower. And we can finish a patient like this very nicely. Let's take a look at this. This is a very good example of tissue engineering again. This is the opposite example of what I showed you. Remember I showed you that you extrude? Now what is going to happen if you want to intrude the teeth? So she comes to us. She was a domestic worker in one of our patients' house, and she says, "Oh, I want to bring, we don't like her teeth very much because she takes care of my children." So, okay, bring her in. We want to do the whole treatment. No. We just want those teeth, front teeth, to be aligned, to be fixed. So how are we going to do it in a patient like this? We normally never take patients like this, but when we see a problem like this, we say, okay, this sounds challenging. Why don't we see what we can really do in a patient like this? So take a look at it. So we put a tad up there, and we are going to basically intrude the upper 2 teeth and bring them up to that level, up to this level. And then what we can do is we can go in and either put crowns on or whatever you have to do. Just the opposite of bringing the bone down, intruding the teeth. So just shows you, and we ended up, our prosthodontic department ended up putting implants in this patient and basically doing something like this. So, simple intrusion is going to change the bone levels in your patient. This slide is out of place. This is a case we actually published it quite a few years ago. Management of severely impacted mandibular canines and congenitally missing mandibular premolars with protraction of transplanted maxillary premolars. So you can see the front 2 teeth were completely gone. So what we do these days in these patients is we create a 3D model of the premolar from the lower, and we are going to create the whole site there based on that 3D model of the premolar. so we can fit it completely. So when we are going to extract the premolar,
khi chúng ta
we
nhổ cái
completely
răng
go
đó
into
ra,
that
chúng ta sẽ có
side.
mô hình 3 chiều của nó, và khi đó thì chúng ta tạo hình theo đúng của nó.
Okay?
Như vậy là lấy cái hình 3
This
chiều.
is not something what we did ourselves. We saw this thing in the
Chúng tôi
literature.
sẽ thấy cái
If
này
people
trong
can
kinh
do
văn
it, we
thôi.
can do it too.
Và như vậy thì họ làm được thì mình cũng làm được trong y văn.
Because we can close the space in the lower without any problem.
Và không có cái vấn đề gì cả. Cắm hai cái răng
So you can see this transplantation.
các bạn thấy
And
cái
then, you
răng
know,
nó được nâng có nhỏ được cái chuyện nó cũng
the patient may not like it very much.
không thích cái
Anyway,
đó
these
lắm.
pictures are out of order. Oh, this is the same patient. I wanted to show you that the lady from North Korea. So you can see we have up to 12 years of retention.
Và có 12 năm đã được
Pretty good,
tốt.
right? Let's see if I have clinical pictures. I do, I think.
Đây là những
Take a look at it. Start,
bước ban đầu,
final,
cuối cùng
3 years,
là đây,
7 years,
là đây. Đây, cô mà được
total transformation.
đây là cái đặc biệt của các khác nhau.
So Dr. Ki-boom, when North Korea will merge with South Korea, all the women there are going to look like her. Right? Isn't that amazing? Look what we can do with orthodontics. The patient just, you know, feels very good about themselves. So I think she lives in the area, and I think she brought her like 7 or 8 year old in the department. So every time she comes in, she says, oh, can we take a picture? Please do. Okay. Now we're not going to go into that. That is area of Dr. Keegan King. We won't talk about that. Okay. Okay, just want to show you one case here.
Tôi muốn cho các bạn xem thêm một cái.
It is here, so why not to show it? You know, we do a lot of patients with sleep apnea, these days because they are coming from all over. You know, everybody is into sleep apnea, and we hate anybody who sends us a 6-year-old or 8-year-old. But we get these patients who have AHI index down, they have had sleep studies, polysomnography and all that. And then if they have real problem, then we are going to do surgery. So this is a patient who came from Yale University by Dr. Steinbacher, and he said, we would like, we're going to do 2 jaw surgery. So take a look at it. I've just consolidated these pictures here just to show you the type of surgery. What we do, we brought the maxilla forward, brought the mandible forward. We are going to create more space in the oral cavity in a patient like this. And you can see before surgery, it's just summary of it. I'm going to show you. And you can see 15 months after surgery. A patient like this is not interested in aesthetics. They want to live. Because they stop breathing at night completely. And it's the index, 18 times, 20 times. I think this patient was somewhere in 20s. Before, 1 month, 1 year, 15 months. Take a look at this thing. Overall AHI index in this patient. And it will show you that when we started, it was a problem. When we finished, it was 2. I think it was 21 or 22. So a lot of these patients, when we do MMA type of surgery, maxillomandibular advancement, you are going to see a lot of changes. The reason I show this is that, you know, orthodontics envelope is expanding completely. And we have to think out of the box. And out of the box is that we have to treat patients who are going to have all sorts of issues. You know, it doesn't make a difference if you're going to use aligners or you're going to use bands or brackets. This is a paper I did quite a few years ago with two of my graduate students, and the question was asked how orthodontics is going to be practiced in 2047. How many years are left? 22 years are left, right? And we talked about that it is going to be genetically driven. Just, you know, we felt that why some patients do better than the others. And that is because right now we have in US, you know, in the genome project, they know everything. We have why patients get, why individuals get class 3, why individuals class 2, and some respond very well, some don't respond very well. So what are the genetic traits in these patients? So I thought I'll show you some of these cases to give you an idea of how we are changing orthodontics. I have to pull this thing out, otherwise. It's still not repeated. Okay, we're going to go back to our.
Chúng ta quay trở lại.
Okay. Hello.
Hello.
Oh, it's okay. Sorry for disturbing you. He's sitting between two beautiful ladies, and you know.
Dạ, xin lỗi là xin lỗi là anh đã còn với hai cô gái xinh đẹp, cho nên xin lỗi anh đã phía này. Cũng ngồi đây hai cô.
So we were talking about midline problems, right? So now we're going to talk a little bit more about midline problems, how we connect. So take a look at this case.
Cái này về đường giữa mà.
Class 1 on this side, class 2 on the other side, the midline is off completely in this patient. Okay? So, let's take a look at it. How are we going to work on this patient? We would like to move the upper slight inclinations as well as the lower on one side or the other. Come on, this is very...
Giang có cái laser pointer nào tốt đổi cho thầy giúp Giang, nói cô Giang thử đổi dùng cái laser pointer này. Dạ. Cái này nó hơi chậm.
Try this. This has to go there then. Maybe my fingers are better. See that? My computer knows my fingers. I use this. Okay, I'll go there.
Dạ, đây sẽ ra chúng ta có một cái mới rồi.
So take a look at it in a case like this.
Xem một cái ca như thế này đây.
So far we were talking only about intrusion arches, cantilevers, beta titanium wires. But this day and age, you gotta be using TADs also. So how many of you use TADs
Có bao nhiêu
in
người
this
dùng
room?
lát giờ tay đây, có ai dùng biết giờ
How many?
Dạ, ai dùng giơ tay.
Raise hands higher.
Dạ, giơ tay cao đây, thầy nói giơ tay là kiểu nghĩ là giơ
not
tay
many
cao,
of you,
không có
okay?
nhiều người là dùng biết đúng không?
So If you're not using tags,
Và nếu các bạn không biết
please learn.
phải
It's
học
very easy
và
because
học
you
cái
can
cách rất là
do
dễ
some
dàng
wonderful things.
mà chúng ta có thể làm.
So in this patient,
là rất là dễ dàng và
we have put in infrazygomatic tag
chúng ta sẽ
only
đặt cái
on one side.
viết zygoma.
And what we are going to do is we are going to retract the canine and put the molar into class 1 position before we change the midline.
Trước khi chúng ta đổi cái đường giữa.
Don't work with the midline because there's no space to change. You have to create space just to the lateral. So go to the molar, make it into class 1, canine, create a space, and then you can start shifting the midline. So this becomes very important. So we have infrazygomatic tag there, infrazygomatic tag there, and we are basically changing the midline in this way. Now, how do you intrude?
Làm thế nào chúng ta luống?
I don't like to intrude with tags
Tôi không thích
at all.
với
So
lại cây
just want I put this example there.
và tôi
So, for example, there are two tags going on to intrude the lower. I can do much easier because we tried this thing, and I always show this to tell that the inclusion wire or cantilever can do a much better job than putting a tag to intrude. If you're using aligners, it's a different story because aligners usually do not effectively intrude the teeth. They do not effectively intrude the teeth because it's very difficult to control the long axis of the teeth. Now we have seating elastics going on, we have space distal to the laterals, and we can finish the patient very, very nicely. Whenever you finish the patient, you never want to finish the patient like this. Okay, when I give my lectures on finishing, in one of our books, Dr. Rene and I wrote a whole chapter on finishing. The mesial distal cusp has to be down. That means the roots are distally inclined. If this is high like this, it's not good. So how do you learn from your own patients? You got to take pictures before, during, and after. And then you look at them, and then you say, oh, next time I'm going to do something better. And I do better. So you can see the tags have been used very effectively in this patient to fix the midline without too much of a problem. Okay? Let's move faster. Come on. So now just show, oh sorry, just wanted to show you before and you can see after. The another thing with tags is going to be that most of the treatment you can finish in patients about anywhere from 14 to 16 months, even faster, if you know how to take control of everything. Arch form, upper and lower. We don't like to use braided wires in the lower 3 to 3 because these braided wires have the tendency to unwind and you can have the canine go forward. The lingual root is going to become prominent and you're going to have a lot of problems. So we like to use these days wires which are on a spool. So when you are putting 3 to 3, you are bonding and there's no tension between them. I was lazy at one time and I would just cut the wire and just put it there and then patient will show up with a lot of problems. So you don't want to do that in your patients. Again, long axes of the
chiều
teeth
dài của các răng
have to be pretty
và
parallel.
nó phải
And one of the things I always
đây là một
teach
điều mà tôi
is
phải
don't
dạy
take panoramic film at the end of the treatment.
trên các chụp vào lúc kết
Take
thúc điều trị.
panoramic film 3 to 4 months
Và
before
3
you
đến
think you
4
are done.
3 đến 4
Because
tháng
now
trước khi
you
xong
can
điều
put the
trị
brackets
thì mình mới
again, you can change,
và như
look
vậy
at the
chúng ta có thể
excellent
thay đổi
nations, you can finish the
và
patient
chúng ta sẽ
nicely.
hoàn tất cho
At the
đây
end of the treatment,
và kết
you've
thúc
already
điều trị.
taken everything
Cho
out.
nên sau
So
đó
it becomes just like a history.
đó, cho
You
nên chúng ta
can't
phải
use it for
chụp
treatment.
nó trước 3-4 tháng rồi.
Everybody got it?
Đừng có chụp
Say
sau.
yes.
Yes thì nếu hiểu rằng nói yes.
Don't take panoramic
Đừng có
film
chụp
at
đi
the end.
vào
Take
lúc
3 months
kỳ
before.
xong á, rồi mới chụp hình
Or
hôm nay,
before you
phải chụp
take
3
the
tháng trước đó để lấy
brackets
cái đó
out.
để mình mới
So
làm
you
cái
can
đó.
do some finishing,
Cho
good
nên trước khi
finishing
chúng ta
in
gắn
these
mắt lại thì chúng
patients.
ta phải finishing chứ còn chụp xong
So,
làm xong mình chụp hình hôm nay.
it becomes very important,
Và
you know,
quan trọng.
using infrazymatic,
Đây là một
zygomatic.
cái zygomatic
It takes about 1 minute
và chỉ
and
cần
34
và
seconds.
như vậy người ta thấy
Actually putting the
45
screw
giây
in.
là có thể là bạn
It takes another 4-5 minutes to infiltrate.
và chúng ta thấy
With local
cái đây
anesthetic.
thì là có
And
mấy
you can start applying the force right away
đặt
after
liền
that,
liền sau khi mà bác viết vào
without any problem.
không có vấn đề gì hết.
I worked with Dr. Marshall Almeida. He's been coming to me at UConn since 2010.
Và 2010
Excellent
đây
papers.
là một cái bài
We've
báo
written
xuất bản.
many papers together.
Chúng tôi đã xuất bản rất là nhiều.
Take a look at this case.
Và hãy xem cái này.
Talking about midlines.
Đây
Take a look at this midline.
giữa đây
Completely off.
hoàn toàn đây
Molar mesially inclined.
và cái răng
Little bit of crossbite.
và cảm cái
On that side, you can see
và
full
đây
cusp
chúng ta
plaster.
có một cái hạt hai nguyên một mũi
Midlines of 3.5
và
millimeters.
3,5 ly.
And if you look at the molar, it's about 5 millimeters, I think. Or I think it's 5, not 7.
Và tôi nghĩ là 5 ly chứ không phải
5
tôi
millimeters.
nghĩ
Okay?
phải nghĩ
Class 2.
là 2 5 ly.
We want to do this midline correction
Cái sinh chỉnh này
and the molar
và
correction,
răng gối
non-extraction.
không có chỗ ra.
Okay? So there's our patient.
Đây là bệnh nhân.
So when you look at this arch form,
Và khi các bạn nhìn
you
vào
say,
cái form
oh, this looks very
này,
nice.
trông rất là đẹp.
But in orthodontics, you have to look at it, like a plane, You can go like this, you can go like this. So how the movements are taking place. So arch form looks good, but basically the whole arch is like this. You have to correct it like that. So if you take a mid-palatal raphe, you can see how it is off. You can see where it is and how would you like to correct it. And this is where you are going to see on one side the molar is class 1, on the other side the molar is class 2. So treatment planning, we are going to do unilateral displacement in this patient. 9 means it's the 9th month. And the protocol we are using in this one is copper nitride. We are going to start with 14 by 25 and sequentially we are going to go to higher numbers. So what we are going to do here is we are going to place infrazygomatic tab. So let's take a look at it. So we have already infiltrated with local anesthetic. I just want to show you one, okay? And now what we're doing is we make a scribe mark in the bone, in the zygomatic bone. Now you're going to take your screw. So it takes about 5 minutes before infiltration, etc. has taken place. And now you're going to take it and with the hand you're going to basically turn. This is actual movie,
Và đây là
just to show you how long it is going to
chúng ta
take.
thấy là nó mất
1 minute and 34 seconds.
1 phút 34 tức là 35 giây, 1 phút 35 giây.
You don't need too much
Và
force.
không cần dùng lực mạnh.
And then you are going to basically shake it gently and pull it out.
Và
That's
lắc
it.
nhẹ cây, rút cây cán ra, rút cây tay ra.
So different companies have different systems.
Công ty khác
Done.
nhau có các cái kiểu dáng khác
Finished.
nhau. Của này xong.
You don't need a special class. You can see 3 times this video, you can do it.
Chúng ta sẽ
Then-
lấy 3 lần chúng ta làm được, không
Okay.
cần đi học cái lớp nào.
Now, one of the things is when we put these screws, they are a little bit to the buckle.
Khi chúng ta đặt nó về phía mái.
So you have to be very careful that your arches don't go like this. So a lot of times you would use a parallel arch or whatever it is, but you want to maintain your buckle width in these patients. So take a look at it.
Chúng ta cần phải có cái phù hợp.
So now,
Bây giờ
when one of the books we did was on tags. Actually, there are 2 editions of that book too. We always talk about the line of force in relationship to the center of resistance of the upper teeth. So now in this case, what we are going to do is we have a very heavy wire going on in the upper arch, because we would like to move all these teeth as one unit. And now you can see on this side we are using a hook, and the height of the hook is going to be changed during the treatment, because the movement, the motion of these teeth is going to be different as you go along. So now we are using beta titanium. This is TMA, 3rd generation TMA we developed a few years ago, 4 or 5 years ago. And we are not using class 2 elastics because it will lift the occlusal plane up on that side, and you'll have a problem. So we don't want to do that. We would like to use a force parallel to the occlusal plane. But even if you use the parallel to the occlusal plane, sometimes you develop problems, so you may have to use a class 2 elastic or seating elastic. So remember, this is one-sided you are using, not on 2 sides. So this force system becomes very, very important. How much force you want to use? 250 grams is more than enough in these patients. You can use 300 grams, but 250 should be more than enough. Okay? Now, the middle of the treatment, you are always telling the patient to smile and look. Occlusal plane is a little bit off. What does that mean? On this side, maybe I have to put a class 2 elastic and a seating elastic on this side. So you will see here, class 2 elastic to bring the occlusal plane. And then I always use a braided wire, sometimes stainless steel braided, sometimes a copper nitride braided wire, because these braided wires then do not have nitride type of response to go back to, bring the teeth back to original shape if you remove the wire. So we do the seating, and we finish the patient. Good midlines, before and after. That was the side which was class 2 by 5 millimeters. And then that side, maybe the distal buccal should be down a little bit more. But the occlusion overall looks pretty good. And the total treatment time is about 21 months in this patient. So you can see the tipping, not good because you have to upright the rhodoapices in this patient a little bit more.
Và chúng ta cần phải
So the sequence which I teach, usually 014 copper nitride, 14 by 25, 4 to 6 months, 1725 in this patient, 2 to 3. And then we use basically beta titanium till the end of the treatment, and sometimes the braided wires. So this was one of the articles we published in JCO. It was on one couple and two couple system and how we are going to use different force systems. So since we are talking midlines, we can talk about aligners also. So you can see these days we use primarily shape memory aligners. But you can see in this case, the midline is off. And if you want to use, for example, aligners to sort of a movement of the posterior teeth sequentially, it's going to take you a long time. For example, this doesn't look very class 2 because the way the camera angle is. When you look at the scan, for example, in a patient like this, you are going to see it is class 2. Because you cannot have a midline off without having, there's no canine block or anything. So don't be always fooled by what you see with the photographs with the camera, because I can move it around and things will look quite different. So, what we can do in a patient like this, if I want to move very fast, I am going to use a infrazygomatic tap in a patient like this. And what you will see is light force, infrazygomatic tap, and I'm going to basically apply a force to bring this canine back along with the other teeth. Very fast treatment in a patient like this. (28) aligners, changed every week. Midline is on, buccal occlusion is perfect. And now you can look at the scans. You can see it needs a little bit more. And you can go back and you can finish it up. So total treatment time is about 7 months in a patient like this. So you can use these. Oh, I wanted to show you one thing. So one of the problems, I usually show this case that we use this one with Invisalign, okay? If I'm doing the same case now with shape memory aligners, I don't need refinements. So in this case, the patient, the major treatment is done, 28, but we use 2 refinements in this patient because occlusion was not good. So you keep getting, so why are we using refinements? We are using refinements because the tracking of the tooth movement did not take place along with the changes each and every aligner was showing. So that's why we these days like shape memory aligners, because I don't have to do it. Because I'm going to make 7, 8, 10, 15 aligners and check patient every time, do a scan and do it again. Instead of getting all the aligners at the same time and then beating your head at the end of the treatment in your patients. So this is a very good example of why finishing is going to take another 12, 13 weeks in your patients. Okay? So you can see the finishing is taking a long time, and the total treatment is now 14 months in this patient. So this is just the opposite example I like to show that why we have problem with all these finishing in these patients. Alveolar bone asymmetry.
Thì cái xương ổ nó là bất đối xứng.
This is a very interesting patient. You know, we treated a few years ago.
Đó là bệnh nhân chúng tôi điều trị cách đây mấy năm.
This patient was in my faculty practice.
Và bây giờ đang ở trong
Take a look at the occlusal plane.
của đây là mặt nhai nó bị.
Take a look on this side.
Và nhìn ở đây.
This is a mess.
Đây là
Okay?
cái đám đó
So,
là đúng.
two ways to treat this patient. Either you do it right, or you send it to your enemy.
Nếu mà bạn muốn là
Okay.
tốt hay là đưa gửi đến cái đối thủ.
So when the patient like this comes in university, all my residents are looking at me and saying, how's Dr. Nanda going to treat this patient? Very difficult to treat this patient. So what do we want to do in this patient? Well, this side is class 1, that side is messed up. So we want to do is intrude these teeth this way, and then we want to intrude these posterior teeth that way. We want to extrude the lower teeth up this way. So you see that? Intrude on this side, extrude the lowers, intrude the uppers. So you need a sequence. What is going to be done first? What is going to be done after? And this patient, you don't want to see a patient as flat mandibular pain. It's almost like frontal horizontal and mandibular pain almost are parallel with each other. So when a patient like this comes to you, you say, where was she for the last 55 years? Right? And why is she coming now? You know why she was coming? She was single for 20 years. She was going to remarry. And she said, I want my teeth fixed before. I said, it's going to take you at least 2 years to have them fixed. She said, I can wait. I've waited all these years. I want my teeth fixed. So, there we are.
Và đây chúng ta thấy tình trạng thế này đây.
Okay?
Yeah.
So we're not going to go into. So now,
Và bây giờ
we have no space to put the brackets.
chúng ta có cái
So a lot of times what we do is we take these polymer wires, a small piece of wire. At one time Dr. Burstone was working with these polymer wires because we were going to get out of these wires, stainless steel wires and all that, and we were going to use these polymer wires, but the problem was that we could never get enough elasticity. We tried to treat so many patients. There was a company in Connecticut which was working with us on these wires. So when he passed away, dropped it because we had given all the rights to sell it, but never came through. Anyway, so now we have this single tag. But one of the things is I hate putting tags for active force on the buckle side. They become loose. So this is going to become loose. So we have a cantilever which is applying the force on this side. Now in the upper, you can see what we are going to do is, this is how things look like. And what I would like to do is a parallel arch. And then I would like to put two tags on the buccal and on the lingual side. And I would like to include the buccal segment all the way up. So you can use coil springs, you can use elastics, but we are using parallel arch because I don't want to lose the transverse relationship. So parallel arch is away from the tissue, so that when you are intruding, you have a space to go up. See this? It's very easy to do in animation. Very difficult in patients' mouth. Okay? Now in the lower, you can see what we are doing. This is how the things look like. This is my tag. This is my little cantilever. And I'm applying a force. And that moment is not a problem because I got it down. So these tags become loose. So now what we started doing is we take two tags, one on top of each other, take a flowable material and embed the wire in it. So now we have two tags instead of one tag. Okay? So now you can see applying the force in this. So take a look at it. So biomechanics, you see in the upper, I already included. Now in the lower, I'm going to use the same tag which is in the upper, and patient is going to use the elastic. So on this side, you can see what is going on. And on the other side, same tag is now going to exclude the lower buccal segment. You're going to have two tags to bring the lower buccal segment. So usually what we do is we make these drawings in patient's chart, or sometimes take a picture in the computer, we put it there, and we say we're going to follow this game plan. We don't say every time patient comes in, look at them, oh, I want to do it now, you know. You got to have a plan right from the beginning, okay? So, then we are looking at the moments, what is going on. You can use even elastic from the inside if you want. So now let's take a look clinically what is going on. Upper is the problem. Lower you can see this tag became loose. So now we go in this area. So you can see we have intruded this quite a bit. We intruded the upper. Now we are trying to bring the lower up. And now you can see in the lower arm. So I put everything together in one picture so I can show you more cases. Not 100% we want, but it is 80%. So you can see we go from there all the way down here. This bone, big, thick cortical bone. Not very easy to move teeth through this bone. So there we are. You can see how we went ahead doing it. And now you can see laterally. So you can see when we were using these tags, these are like multi-user tags, intrusion, retraction. You can do all sorts of things, pulling the more teeth out. Now if I use these mechanics, I can do alignment cases also with the same type of mechanics. Sorry. I want to now this is very important because a lot of times people put in parallel tags and they forget about it. Okay? And they say, oh, when you use these parallel tags, you can see we are changing the configuration and the force system all the time. And you can see we are applying the force for inclusion. At the same time, palatal arch, so I don't create any constriction. So there is our patient. The smile looks good. I saw the patient recently means about 6 years ago. She's divorced. She married and didn't last too long. But that's a side story, you know. It's a long story she gave me, but it's a side story. But nothing to do with our orthodontic treatment. But take a look at it. A lot of these patients you will see, they by the time you move, so she came to us at this time, she had lost her lingual retainer and spaces opened up, and she waited about 4 months or 6 months, and she said, "Now, can you please close my spaces?"
Và nó mất 14 năm tháng rồi và đang chạy, bây giờ cũng đóng mở lại.
Okay,
Dạ.
so you can see the occlusion. You know, the upper arch turned out pretty good. It's always the lower arch which is going to give you a problem. The upper arch occlusion means you can do a very good job. Lower is always the problem. Why lower is the problem? Because you cannot intrude the lower posterior. You can extrude them, but intrusion is forget about it. Posterior teeth is almost
Các
impossible.
răng á, hàm dưới nó khó lún, hàm sau
Okay.
khó lún lắm.
Okay, one more case I
Đây một
want to
cái
show
nữa
you.
thì chúng tôi sẽ cho các bạn
And
xem.
this is like
Cái này là
maybe a
giống
couple of cases. So take a look at this
Và
case.
chúng ta sẽ xem.
So we, Junji Sugawara and myself, we started in 2009. We published our first paper on surgery first, and since then we published maybe 10-15 papers
Và
on
sau
this
đó thì chúng
subject
tôi đã có 10
all the
báo
time.
về chủ đề này.
And I want to show you.
Và tôi muốn cho các bạn biết
This is just to impress you how many
đây
patients
là
are there.
để
Case. No, okay, forget about it. I want to show you the case.
Rồi,
Okay.
cái chủ đề này
So take a look at
tôi
this
để
case.
tôi cho các bạn xem cái ca này đây.
She was one of the first cases,
Đây
you
là
know,
trong
we
cái
did
đầu tiên của tôi là
with our friend Dr. Carlos
bác
Villegas,
sĩ là Carlos
class 3 case.
khoảng 3 ca.
In those days,
Và những
we
ngày
did
đó
not even use CBCT
chúng tôi thậm chí không dùng con
on this
BCT
patient.
trên bệnh
So
nhân
I
này.
want to show you the first page. How do you develop
Và
a
chúng ta đã
system?
phát triển cái hệ thống hệ-
So, surgery first means
phẫu thuật trước có nghĩa rằng
that we put the brackets on, put the arch wire, and the patient goes for
đây
surgery.
và bắt áo cào gắn dây cung vào.
Right away, you know, in the first 2 months,
Và
patient is
trong
going
2
for
tháng đầu
surgery.
tiên là bệnh nhân sẽ được điều trị liền. Nó được các
So 3 weeks after surgery,
3 tuần sau khi
the idea is we want to take advantage of the rapid acceleratory phenomena. The teeth are going to move faster because you have big injury, and the cells are going to come in, and the bone density will get less, and tooth will get much faster.
cho nên chúng ta sẽ di chuyển răng
It
nhanh hơn.
works.
Cho nên nó có hiệu quả.
So there's our 8 months of
Đây là
treatment.
8 tháng sau khi điều trị.
A lot of things could be better. So you can see initial 3 weeks, 6 weeks to 5
Ban
months.
đầu 3
1 year.
tuần, 6 tuần, 3 tháng, 5 tháng, 1 năm.
So the idea of surgery
Và
first
cái
is
ý tưởng về phẫu thuật
instead of telling a patient
và nó sẽ cho
things don't look good in your mouth, but I'm going to make them worse for a year and a half with pre-surgery, and then I want to make it look good. And the patient says, wait a minute, I came for my aesthetic reasons. So now we say, okay, we put the bones together, and then we're going to align the teeth, and teeth are going to move much faster in these patients. So just wanted to show you that our first patient, how she looked like. And we basically followed this patient 13 years or 12 years. Okay. I don't know if I have pictures in here or not. This is up to maybe 10 years.
Có thể đến 10 tuổi đây, 10 năm đây.
Okay. So people always say, oh, how's the retention?
Và các bạn hãy nói
Fantastic, she's a healthy patient.
vì bệnh nhân rất là tuyệt
She
vời.
looked good.
Bệnh nhân trông rất là đẹp.
I always finish my lectures when I talk.
Khi tôi
I
thuyết
always
pháp
put in patients with craniofacial anomalies.
và những cái
My PhD was cleft lip and palate.
cái tiến sĩ luận và tiến sĩ
All my life,
và
I
và
treated
thay hở môn.
hundreds
Tôi trong
of
đời đời chúng tôi đã
craniofacial
trong
deformities,
những cái dị
anomalies.
tật sọ
When I did my American Board of Orthodontics,
và khi tôi
I
làm
was supposed to bring 12 patients,
và tôi có
and 7 of my patients were
7 bệnh nhân của
cleft
tôi.
lip and
Đó
palate,
là
and they
cái
said
thay
we're
hở
going to fail you. I said, why? Because you didn't bring class 2, you didn't bring this. I said, wait a minute, they have class 2 also.
Tức là khi đó
So I had a big fight with them there, because now things have changed. Now they don't even bring a case.
Mà như vậy thì những cái
So-
bệnh nhân đó khó mà đạt được các cái
So take a look at this patient. So always treat these patients with compassion
và luôn
because they really need
có
help.
lòng từ bi.
So
Với cái
look at
lòng,
this,
lòng
she takes
ban sự,
medications.
lòng từ bi,
You know, she has
yêu thương đó.
lot of issues. This is basically type 3. You can see the ears are a problem on one side. And dentition, you can see a lot of issues. Number one, you are going to treat occlusal pain, space maintenance, space closure exactly the same way as any other patient you are going to treat. But these patients are also going to need surgery. And you can see she's missing teeth. All kinds of issues are going on in her mouth. We are going to do surgery with this patient. So take a look at it. She has no condyle on that side. Completely condyle is missing. And you can see all the ramus development never took place. And you can see the body of the mandible is all up. There's no gonial angle. Okay. This is her occlusion looks like. And you want to change her occlusal plane. So remember I showed you how to change the occlusal plane? Even if you do surgery, you still have to change the occlusal plane in these patients. Biomechanics is the same in all these patients. Completely. We do surgical planning with our surgeons. And you are going to see on this side, we want to replicate this side on the other side to get this patient's symmetry. This is how things look like. And in the surgical plan, we are going to move the mandible first because that's where the major issue is, because the mandibular development on one side did not take place because the condyle is missing. So you are going to bring, you can see how far you are going to bring the mandible in this patient. Only on one side. And then the next thing what you are going to do is maxillary advancement you want to do. And you can see maxillary advancement, how it looks in relationship to the problem, and take a look at the amount of gap you are going to create on between, on one side. Huge amount of gap which is going to be. Then what you want to do is you want to put upper jaw and lower jaw together. Take a look at the occlusal plane is good. How much we brought the mandible forward. And then we have a gap in there. So we are going to do a three-piece LaFleur, can correction, yaw correction, 5 millimeter advancement, posterior disinfection, mandible moved into occlusion. Take a look at the amount of gap we have in this area. So the problem, the mandibular problem has also created the maxillary problem too at the same time. So you can see the type of movement we are going to do. And at this time, the company we work with, they are going to give us transitional splints, surgical splints, and splints we are going to use at the end of the treatment. We are going to do genioplasty in this patient also. So take a look at the amount of overlap. Take a look at the asymmetric movement of the chin. You know, the interesting thing is oral surgeons don't do this thing. We as orthodontists try to do it and tell them, hey, I think this looks better. So we give them credit, hey, you know, look, this is what we would like to see this patient. This is what the surgeon gets. He puts it right in front. When he's doing surgery, this is in front of them because that basically tells them each and every movement which is going to take place and how much movement is going to be. They don't get it all the time. Instead of 4, sometimes we get 6. but at least it gives them exactly what type of change we are going to expect in our patient. These are our intermediate splints. Take a look at that splint. We don't create these splints. It is like Synthes or Materialize or somebody, they are going to do these splints for us. Maxillary teeth, mandibular teeth, these are final splints. And then we are going to use this device basically for fixation of the chin. And this is how the patient looks like 2 months after the surgery. So now you can see the occlusal plane. We have to lift these teeth out to bring them to proper occlusion. Remember how steep our occlusal plane was? Take a look at the occlusal plane. So one of the nice things is for the first 4 months, the tooth movement is going to be very fast because of the wrap phenomena. After 4 months, it becomes less, and the wrap phenomena basically goes away by the 9th month. So we try to finish all our patients before 9 months with major tooth movements in these patients. This is 5 months after surgery. She took much longer because a lot of other things were going on in this patient. So took us almost 2 years to finish the treatment. Take a look at the amount of hardware she has in her mouth. This is 6-month retention. She has dental work done. Patient is very happy. This is a major change for a patient like this because they can eat now, they can chew, they can socialize. This is 12 months of retention. She may need some other surgeries as she go along, but it depends on the patient whether they want it or not. But she has other issues, missing ears and all that hearing problem and everything else which goes along with it. So this is, you can see how she looks now, before and after. One of the things we basically told her, because you can see with hemifacial microsomia, everything is down. So you know, there are some changes with her eyebrows also to make them even, because it's the eyebrows which you look at it. So her face on one side, she's down. We work on that. We tell the patient to do that. So you can see where we were, where we are in the patient like this. So I always show this as my last patient because I think I always want to instill in all of you that these patients do need a lot of help, and always try to treat them like any other patient. Same mechanics, same everything. Whether they need surgery or whether they don't need surgery. Okay? So I think with this, where is Dr. Vithong? Should we finish or should I show a couple of more cases? What? Okay, one more. All right. Bonus. I'll show you a bonus. Oh. Okay, I may show you 2 cases. How about that? Okay. So take a look at this patient. Oh. Asymmetric patient comes to us, and now I want to show you how fast sometimes we can treat these patients if you do surgery first on these patients. Take a look at it. Midlines are off. Take a look at occlusion. Glass 3 on that side, glass 3 on this side. If you block her The area below the nose,
và chúng
very
ta
attractive patient, very expressive eyes.
che cái phần dưới
Beautiful.
cái mũi lỗ mũi
And we
cái
want to
này.
make her exactly what she
Và
should
như
be.
vậy chúng
Okay?
ta cần phải làm từ mũi
So,
trở lên thì
we are going to
ok,
analyze.
phải xấu rồi.
Anytime we see this problem, we give these patient technician 99 just to see if there is one condyle which is hot and one condyle is hot in this patient. So what we are going to do is condylectomy in a patient like this. And this is virtual skull model. Just to show you the type high condylectomy we will do, take about 2 to 3 millimeters of condyle in this patient. And this is the treatment plan we are going to do. Asymmetric mandibular impaction, the foremaxillary advancement. And you can see in the lower, no overlap on that side. This side we are going to move the mandible forward. This is pre-treatment, 3D prediction. So, in this patient, what we did was, one of my graduate students, Rohit Sachdeva, we were given a arch form making machine by a German group. They had made about 6 of them, they could not sell them. And Rohit said, okay, I'll take one, and he started his company, Sure Smile, in Texas. But the company basically failed over time. It didn't work out. But the idea was, I said, Rohit, can you give me 2 finishing wires? So I just used 2 finishing wires in this case. So, this is how the 2 finishing wires came in. Copper nitride, placed 1 day before surgery in the mouth. Condylectomy is done. 3D digital splints in the mouth. 2 weeks after the post surgery. Now take a look at it. The occlusion is not very good, but the wire is very active. All the placement, finishing placements are being done in this completely. 2 months after surgery. 4.5 months of treatment in this patient. Total. 4.5 months. Fast. She looks better than 3D prediction. 4 months post-op. 1 year post-op. She looks better and better and better, every time. I have pictures of more pictures of her in another. Take a look at her jaw, how it was before, and how she is now. So what we are saying is, sometimes the surgery first, we can do some amazing things with patients very, very fast. Instead of telling the patient, oh, we are going to see you after so many days and all that. So we don't do that, okay? I think we published one of these. Okay, one more. The last patient, this is Dr. V. Thong special. Okay, I'm going to show this case. Take a look at this case, right? It is reverse of tissue engineering. Take a look at it. So this young girl was treated at an early age also, but if you take a look at her this side, you can see it is like a little bit compressed, and she didn't like that at all. In her jaw, you can see it problem. So what did we do? We took a 3D, we took example and we created a 3D replica of exactly how much we are going to need just to compare, have the both sides the same way. We use sort of a light acrylic kind of thing. Okay, you can see how it compressed on that side. So there it is. We create this
ta lấy bản sao đó chúng ta ghép vào vị trí
CAD cam.
và CAD cam.
And you can see, you know, just methacrylate and
Và chúng ta làm
3D
cái này
printer.
bằng cái methacrylic để là
And we use medical school 3D printer because a lot of these head injuries, when they come in, they create all these 3D printing vehicles. And we go in and we screw it on the ramus, finish up the patient with the rest of the treatment. And there she looks like during the treatment or after the treatment. And you can see we've been following her for ages also. No issues, none whatsoever. These are the pictures when we were treated when she was younger, 3 years younger. Okay, so this picture should be there, and that should be there. Okay. We have followed her for a long time. So you can see, you can use 3D printing. Now we do 3D printing to do aligners. We make them in the office. You know, we don't send the patient, we don't send to the company, we make them ourselves. This is the real end of the slide. So, I really want to thank Dr. Thẩm. He ran away. Oh. So, I want to thank you very much. I want to thank Van Lang University very much. I want to thank all of you very much for sitting through and listening to my telling you to buy a Corex, use tags, use shape memory aligners, and think positively about orthodontics. Okay? So thank you very much.
Mọi người, đây là thầy năm nay đã 83 tuổi rồi. Em xin mọi người có thể tất cả cùng đứng dậy và cho một tràng pháo tay thật dài được không ạ?